My name is Antonya Williams, Master Prepared Adult Gerontological Acute Care Nurse Practitioner. I'm a student at the University of South Alabama, and this is my DNP capstone project, Sepsis Bundle Implementation. Some people may be wondering, why is implementation of a sepsis bundle so important? If we look at it globally, the global burden of sepsis affects about 20 to 30 million people annually, with a 50% mortality rate and annual costs of $24 billion. It is the leading contributor to ICU morbidity and mortality. Myself, being an AGA-CMP, I will likely provide care management for sepsis patients, considering nationally, sepsis and septic shock patients have one of the highest admission rates to ICU, with mortality greater than 60%. Mortality increases about 8% with each hour in treatment delays. So implementing a sepsis bundle and initiating early antibiotic therapy, mortality can be reduced by 20 to 30% within the first hour. Sepsis contributes to vasodilation and increased permeability, which leads to intravascular fluid deficits. Therefore, it's important that fluids are timely to prevent volume depletion. Recommendations suggest antibiotics should begin within the first hour of diagnosis to prevent the cascade that sepsis has on the organs and pretty much prevent organ failure. The key elements with vasodilation and volume depletion are usually direct contributors to mortality rates associated with sepsis. So therefore, by implementing the bundle, we will be able to reduce mortality 20 to 30% if we can do it within that first hour. Now we look at the purpose. What's the purpose? What happened? Why did this become such an important issue? Well, the Center for Medicare and Medicaid Services identified sepsis as the second most common and costly discharge, with 400,000 discharges and a cost of $5.7 billion in annual costs. So the response to sepsis was to introduce it as a core measure in 2016. So in 2016, sepsis was introduced as a core measure, and the facilities that get Medicare funding, they put it on their radar to watch it to see if we implemented programs or implemented ways that we can recognize sepsis earlier and start treatment earlier. Will we get any better response as far as mortality, as far as costs, and things of that nature? So I had to look at what was my facility doing. This was implemented in 2016. So what was my facility doing as a response to this? And when I look back retrospectively, I saw of the 289 patients that were diagnosed with sepsis in 2016, my facility was only 9% compliant with the CMS required core measures of early sepsis intervention. We did an in-house patient assessment which identified sepsis as a leading contributor to ICU morbidity and mortality. The average mortality in our ICU was 40%, and the cost of care was greater than $5 million. So these two factors alone was enough to say that we needed to be doing something to improve those outcomes. Once we looked at the information that we'd gathered, we had to develop a PICO question. And that question was, does implementation of a bundled treatment approach compared to a non-bundled approach decrease mortality, morbidity, length of stay, and costs in adult sepsis patients? My overall aim was to improve the therapeutic response to sepsis by implementing bundled interventions. By implementing these bundled interventions, they would assist with enhancing the facility's treatment compliance from 9% to 100%. So if we could successfully implement a bundled intervention package, we would be more compliant with CMS regulations of treating sepsis or early recognition of sepsis from 9% to 100%. Thereby, if we implemented these bundles and that we were successful with them, then we should see, according to research, we should see a decrease in morbidity, decrease in mortality, decreased length of stay, and decrease in costs. Now, When we're looking at the need to take action, why is it so important that we take action with sepsis? Sepsis is a medical emergency. Sepsis in adults is a medical emergency that requires early recognition and rapid intervention for preservation of life. It's also a global burden. It's not just something that we face here locally in the United States, but globally, everybody deals with the effects of sepsis. We talked about before, it's a 20 to 30 million persons annually are diagnosed with sepsis, and it's a 50% mortality rate associated with a $24 billion cost. The rise in costs with sepsis awareness being a global initiative, the rise in healthcare costs is expected to increase greater than $3.4 billion in a 2-year period. We talked about the increased mortality that's associated with sepsis. And if we look at the mortality, compelling research suggests that early interventions with the use of sepsis bundle protocols is 3 to 4 times more likely to save lives as opposed to not embracing those protocols. So, what did we do? We had a sample size of 48 adult patients, 18 years or older, with a diagnostic-related group classification of sepsis, septicemia, urosepsis, and septic shock. They were the persons examined within this project. Now, we excluded patients that had a known DNR, the patients that came in that were trauma patients, patients that had acute MI, patients that presented with a stroke, or any type of trauma where life-saving measures were necessary within the first hour. And we excluded those patients because it was very important for us to start the sepsis bundle once those patients met criteria. Any type of life-saving measures would have pushed back the time that we had to implement the sepsis bundle within. Where did this project take place? It took place in my facility, which is a 189-bed licensed facility. It's a community-sized tertiary facility located in the U.S. territory, and it services a population of about 50,000 people. So, the tools that we use and the interventions that we did. Well, we looked at pre-assessment. We looked at our knowledge base. What did our clinicians, where were they as far as knowledge of sepsis and the effects of sepsis on the body? So pre-assessment, of the 225 nurses and 45 physicians that completed the sepsis questionnaire that was given to them, 80% of nurses and 30% of physicians were deficient in knowledge related to sepsis and early recognition and treatment. So we had to develop a plan to increase that knowledge, to increase that awareness prior to implementing the bundle. So what we did was provide diverse education because there were different types of clinicians, there were different type of learning styles, and we wanted to make sure that we targeted everyone. So all clinicians, as well as anyone directly involved with the sepsis project, had to take a 1 to 2 hour live education session. If they were unable to do the live education session, then we did have e-learning set up on the computer as modules, and they were required to take those modules. And pretty much the education was related to sepsis, the effects of sepsis on the body, the importance of early intervention, why the need for utilizing bundle interventions, and what our project outcomes were projected to look like. So with the diverse education presentation, we not only had live presentations, we had brochures, we utilized pamphlets, we utilized badge reminders that had a list of the triggers. We also had process maps that would help trigger the memory for persons that forgot, what do I do next? And then we had post-educational testing with the same test that we had given prior to education implementation. The clinicians had to achieve at least 80% on the test before they were allowed to be considered as proficient knowledge-wise. After we did that, we also had to look at how are we going to determine if these patients met criteria. So we used an evaluation for sepsis, severe sepsis screening tool, and patients that came in with a history suggestive of a new infection or infection and another identifying trigger, say for instance, that patient may have come in with infection and leukocytosis or an infection and hyperthermia or tachypnea or any signs of organ dysfunction. Then those people were targeted to see if they met sepsis criteria. Once we're looking at that criteria with the sepsis screening tool, if they did meet that criteria, then immediately we started the bundle intervention on those patients. Within the bundle intervention, it was very important that we not only drew labs to determine what their lactic acid looked like, and that determined their tissue perfusion. We also started antibiotics, and we wanted to make sure that we drew the labs prior to starting the antibiotics. Those patients that required fluid, then we started crystalloid fluid on those patients. Also, if those patients required any type of oxygen administration, then that was started as well. So once the sepsis bundle was implemented, we were implemented within a 3-hour time period. The most important things for us were implemented within that first 3 hours. Then those patients were followed by concurrent reviewers or retrospective reviewers. And what they did was basically go through the charts to make sure, did we follow the process of implementation of the sepsis bundle? How are we progressing with this patient? We use clinical care coordinators in the emergency room for when we had a backlog of patients, so that those bundled interventions could be initiated in a timely manner. And we also had our clinical care coordinators do data extraction from the charts, along with our project manager being myself. The data extraction that we looked at the age of the patient. What was the patient's diagnosis? When was the admission date? Did the patient transfer to a higher level of care? Did the patient progress from sepsis to septic shock? We also looked at Apache 2 scores, because we realized Apache 2 scores kind of looks at the severity of the disease. How likely is this patient to experience mortality? And there are different measures within the Apache 2 score, and a lot of them pertain to advanced age. If the patient is immunocompromised, does the patient have renal failure, or does the patient have multiple comorbidities? And they were likely to have a higher Apache 2 scores if they had any of those precursors. We also saw the likelihood of mortality with patients that had a higher Apache 2 score. So once we extracted that data, once we started to follow those patients, we had meetings on a biweekly basis. We would have small meetings every day just to make sure if something wasn't going right, we would go to the person to say, hey, can we look at this? We missed this here. Can we implement this? So we were very good on making sure we stayed on top of everything with those patients, since we really had a small sample size. The project manager, as well as Sepsis 6 team members, and that team consisted of ancillary staff. It consisted of leadership, as well as physicians, and we would meet together on a biweekly basis, or more frequently if necessary, and we would discuss the progress. Do we need to change something? Do we need to evaluate something? What does our data look like? And speaking of data analysis, we basically looked at baselines, the baseline from previous year of the sepsis medical data obtained from that previous year. We looked at pre and post CMS compliance with early intervention therapy, and that served as a baseline for us in beginning this project. We looked at pre and post implementation of sepsis knowledge evaluation. Where were our clinicians as far as their knowledge related to sepsis? Where were they prior to project implementation, and where were they after we delivered the education? We also looked at the comparison of prior year statistics relative to length of stay, costs, mortality, as well as morbidity. Now the results. Did the project answer the PICO question? And the PICO question was, does implementation of a bundled treatment approach compared to a non-bundled treatment approach decrease mortality, morbidity, length of stay, and costs in adult sepsis patients? So our primary outcome was to improve the therapeutic response to septic patients by implementing bundled interventions. And as we talked about before, our pre-intervention, we were 9% compliant with early recognition and intervention according to CMS core measures. Post-intervention or post-educational intervention, we were 100% compliant with making sure that those sepsis bundles were started in a timely manner. Now, by starting those sepsis bundles in a timely manner, we expected to see our secondary outcomes. By doing this, according to research, we should see a decreased length of stay with our sepsis patients. We should see a decrease in costs related to our sepsis patients, and we should also see a decrease in mortality as well as morbidity. So our average length of stay prior to implementation was 10 days, which in turn created costs greater than $50,000 per hospital stay. So by recognizing the sepsis cascade early and initiating a timely response, patients experienced a 30% reduction in length of stay from 10 days to 7 days. So thereby, a reduced length of stay equated to a reduction in cost. So we saw a reduced length of stay contributed to a 50% decrease in cost from $50,000 to $25,000 per hospital stay. When we're looking at mortality, the average mortality rate prior to implementation of bundled interventions was about 40%, and that occurrence drastically decreased because of the early goal-directed therapy delivered through the bundled interventions. Statistical data identified about a 20% reduction in mortality from 40% to 32%, and there was a positive correlation between mortality and patients with a higher Apache 2 score. It was very difficult to look at morbidity as far as patient presentation because we didn't have any control over the patients that came in with sepsis. Neither did we have any control over the patients that may have returned with a septic event. So we couldn't really gauge frequency in that sense. So what we looked at was that any of our patients that came in with sepsis progressed to septic shock. And we did determine that during the time period of implementation, none of our patients progressed from sepsis to septic shock. Now, there were patients that did progress from sepsis to septic shock, but they were not included in our evaluation. And like I said, most of those patients were either already in ICU, those patients either had a DNR, or they were part of the measures that were not included. When we look at the compliance, like we stated before, we're looking at January, we had 9% compliance, and over the months, we drastically increased and we obtained 100% compliance with sepsis bundle implementations. Like I said, it was very good for us because we did have concurrent reviewers, we did have clinical care coordinators, we did have someone on the floor at all times making sure that once those patients met criteria, the bundle was initiated. The average length of stay, we saw the initial length of stay was 10 days. We did see an increase in February, and I'm not sure directly as to why that increased. It may be related to with our patients in the Virgin Islands or in the U.S. territory, there are no nursing homes, there are no long-term acute care facilities, there are no places to discharge patients. So a lot of those patients, if they don't have family members, if they don't have a place to discharge, then those patients do stay at the hospital until they can be placed. So that may be relative to why we saw an increase in February. But we did see a downward trend in March as well as April, where we had a decrease in length of stay from 10 days to 7 days. Our sepsis mortality, it began at about 40%, and we saw a decline in that as well, down to about 32%. Cost of care, we did see initial starting at about $50,000 per patient per hospital stay. We had the relative increase in February, and that may be in relation to our relative increase in length of stay days, creating exuberant costs for those patients during that month. But we also saw a decrease within the months of March and April. In conclusion, sepsis remains a large contributor to mortality, but clinicians can improve outcomes by early recognition and timely treatment administration. Implementation of standardized treatment processes reduces variability and creates clear, concise, and consistent treatment modalities for promotion of positive patient outcomes. Concurrent and retrospective reviews continue, education continues, and re-education has shown to be a very important aspect towards compliance and sustainability. With our recommendations, is there room for improvement? Of course. With this project, we did have a small sample size and we had a unique setting, being that it was in a U.S. territory, it was in an isolated setting. So we had an increase, we could increase population diversity. With an increase in population diversity, we may see a little variance in those numbers. The use of concurrent and retroactive reviewers served as unique contributors to data accuracy. Like I said, we always had somebody there available to make sure that process was being followed, so that did contribute to us making sure that we had accurate data and timely implementation. Further implications of sustainability with the use of reviewers may not be conducive to utilization within a smaller size facility. Our recommendations would be to continue with the use of structured sepsis bundles, timely review of medical records, and then consistency in the education process to assure that everybody is keen on the awareness of utilization of sepsis bundles. These are my references, and I thank you for your time.